primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever so relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care has allowed me to continue being a doctor. I can't see any other way that I could have continued my career without direct primary care, as it's allowed me to take better care of my patients, better care of myself, and better care of my family.
DPC has offered me the opportunity to be better in all aspects of my life. I'm a better father, a better husband, a better community member, a better physician, and just a better human all over. Direct primary care has allowed me to practice medicine in the way I've always dreamed to practice medicine, and it's kept me thriving in my personal life as well.
I am Dr. Katie Brang.
And I am Dr. Ryan Brang.
We own North Country Health.
And this is our DPC story.
Dr. Ryan Brang grew up in Cottage Grove, Minnesota, and received his medical training from Ross University. After doing his clinical training in New York City, he returned to the Midwest at the Family Medicine Residency Program in Marquette, Michigan in 2009. Dr. Katie Brang is from Traverse City, Michigan, and after completing her undergraduate training at Carleton College, she graduated from the Michigan State University College of Human Medicine in 2009. She also matched with the Family Medicine Residency in Marquette, and this is where Drs. Ryan and Katie met. After residency, they took jobs in a private fee-for-service clinic in northern Wisconsin doing full-scope rural family medicine. They were recruited back to Marquette, Michigan in 2014 to take positions as faculty in their old residency program. While in academic medicine, they educated residents and medical students while working long hours as OB faculty for Ryan and hospitalist faculty for Katie, in addition to maintaining their corporate-owned outpatient practices. They started North Country Health DPC in September of 2022, with Dr. Ryan and then Dr. Katie joining in January of 2023. They focus on preventative medicine, nutrition, sleep, menopause care, and lifestyle medicine, in addition to general primary care. Dr. Ryan does advocacy work as part of the executive committee at the local hospital, is the Upper Peninsula representative on the Michigan State Medical Society, and is on the board of the 906 Adventure Team, which focuses on healthy outdoor lifestyles for kids and their parents. He has completed advanced training in chronic pain management and is a certified culinary medicine specialist. Dr. Katie recently completed training in menopause care and is a certified menopause practitioner through the North American Menopause Society. Outside of work, Dr. Katie likes to ride and race on her mountain bike and is getting back into competitive Nordic ski racing now that her children are a little older. January 2025 will be her first Nordic ski marathon in 11 years. She also enjoys spending time camping with her 2 children. Dr. Ryan enjoys cooking healthy plant-based meals for the family and completing endurance mountain bike events. Thank you so much, everybody, for tuning in. Find out more about DPC, including resources, discounts, my favorite tech tools, books, and more at mydpcstory.com. The mapper, again, has been updated so you can look for practices by specialty. Follow us on your social media platforms at our handle at MyDPCStory, and be sure to subscribe to our newsletter and, of course, the podcast feed itself so you won't miss when the next episode drops. If you're new to the podcast, be sure to check out the blog accompanying the Brang's podcast at mydpcstory.com. So with that, I am so excited to welcome our guests, Dr. and Dr., Mrs. and Mr. Brang. It's so wonderful to have another couple on the podcast. So thank you so much, guys, for coming on.
We're super stoked to be here. Thanks for having us.
So I wanted to get started with, when I went to your guys' website, there's a video on the front page of, Ryan, you talking about your journey and what direct primary care is for people who are checking out your website for the first time, or for your patients to share the website so that more people can learn about the practice from that video. Tell us about these 8 years that you were in practice before transitioning to DPC.
I really want to share this story because I think it is a little bit unique. So I've always been a big fan of the podcast. Thank you, Marielle, for everything you've done. A big part of our journey to get here was listening to the inspiring stories from so many others that have done this great challenge. And so definitely that's been a big part of this. But one of the things that was a little bit different for us is we didn't have that typical story of 2,500 patient panel, just getting overwhelmed with patient care and feeling I mean, we had to deal with some of that, but we came at it from a little bit of a different perspective. And I think it's important to maybe share a little bit of that experience. So Katie and I did do 8 years in education with the residency program. I did a lot with OB, so I was doing OB throughout that time, and also hospital medicine. Katie did the majority of the hospital medicine, and then she transitioned more to outpatient, but we were both full-time faculty for 8 years. And it did offer a little bit more of a buffer for some of that. You know, on the days where we were seeing patients, it was absolutely that feeling of 12 patients in a half day, and then your inbox was always overloading. But we also had some administrative time to be able to work through that. So I would say that it was a little bit different for us. So our primary push wasn't so much that we were absolutely burning out in family medicine, but it was more for me, I'm not providing the care to my patients that they need. They're only able to see me a very specific period of time. They're waiting many weeks to see me. They can't access me. I can't access them. And I thought that was really a disservice to them. There were some other things that were going on in our lives that also kind of encouraged us to say, we need to consider going off on our own. And in fact, in our community where we live, we have many, it's kind of unique. We have many independent fee-for-service clinics in primary care, and we all are really collaborative. There are good friends that we've all kind of come through the residency program, either just ahead of or behind. And so they've been really supportive. And we sat down with a couple friends of ours and they said, you guys should definitely do it. And at the time, we were planning to do fee for service. And so from that perspective, it's been a journey, but it's been one that's been great. And I would say that those 8 years of education have been really rewarding. It's been excellent teaching future generations, medical students and residents. And I still love to teach. So I like that we still have that opportunity to take residents and learners periodically. But it was different for us compared to some other folks that have gone down the path.
I think that it is such a good point to make because everybody is coming from a different background before they transition to DPC, for those of us who have made the jump already. And so I think it's so important for people to hear that you don't have to be burned to a crisp to be able to look for a different way. And with that, Katie, I would love to hear your take on your 8 years in academics as well, because you were more hospice based, because I read recently somebody was irritated with somebody saying that a lot of residents are just going to be hospitalists after residency. And I found that to be the case in my residency, not in my class, but this is like a class of residents I talked with maybe a year ago, where the plan was to go into hospital medicine exclusively because outpatient medicine was such a drag. So I would love to hear your take on you being more hospice focused versus OB focused and what you were bringing to the table as your, like, I also think that this is a good idea to do something apart from what we're currently doing.
I actually think I have a very different answer to this question than Ryan has, because I did my full scope family med for 2 years in northern Wisconsin, and we did rural inpatient, which isn't that complicated. Then I came back here and I was working those 7 12-hour shifts, and I had a newborn and was trying to manage that, and the shifts were often 14 hours, not 12. And by the time I would get done with those 7-day stretches, it was awful. I just can't even describe what they would feel like after being up all night with a baby and then doing 12 to 14 hours and doing it again for 7 straight days. I think that when we think about hospital medicine and hospitalists, we forget that we're asking a lot of people. And you look at those 7 days off that you get, and it takes so long to recover when you're older, like I am, and then you're right back at it later. Now, I did also do outpatient. So I did a 7 on, 7 off, then 5 days in the clinic. And so I did that rotation for, it's funny that it runs together. I want to say 6 or 7 years that I did that. And it was really, really hard on me. And it was hard on the kids and it was hard on the family. And then Ryan also had to take his OB call when I wasn't in the hospital. So when I was off, he was on call all the time. So I think we have this amnesia for about 7 years where we don't remember what happened. And it just reached a point there where we looked at each other once we were financially able to do this. And we we're like, what are we doing? We're making all this money and we're miserable. There has to be a better way.
So you guys, especially because I'm, married to another doctor, also now a fellow DPC physician at Big Trees MD, but I would love to hear your guys' take as to once you realize, hey, we are making all of this money, what are we going to do with it? Our life is not as we would like it to go forward in the future when it comes to family, time with kids, time for yourselves, etc. What was the situation like when you guys decided, yes, one, we're going to go into our own practice, not because you guys are still active in teaching, but like just the idea to go into your own practice versus continuing the hours that you were working? And how did you decide on DPC versus fee for service when you did open your own practice?
So I can take this one. It was actually July of 2021. I can remember this because I had taken a vacation with my daughter and my sister-in-law, and we were on Isle Royal, which is this very remote national park, and we were backpacking. And I had just come off of a really rough week on, and so it was my week off. And I was just in this terrible place. And here I was in the most beautiful place in the world with people that I really loved. And I could not settle down. I just could not transition into this backpacking trip. I was up for days and I just started thinking. And then when I got back, Ryan and I really sat down and talked about the insomnia that I'd been having and what are we going to do about this? Something has to change. And that was it. Like it was that month where we weren't sure what it was going to look like. Was I going to stay in medicine? Like what were we going to do? And then that's when we started talking to our friends and asking them what they were doing. And we sat down with a doctor couple that we know well. And they basically said, if we can do it, we have a 3-year waiting list. Like the town needs more private practice doctors. You can do it too. Then we started talking with other people in town, and one of our other colleagues said, I've got this fee for service practice. I love it, but I wish I'd looked at direct primary care before I opened it. And she said, you guys should look at that. And we'd never heard of it before. And so then that was probably in the fall, maybe early spring of 2022, as we were kind of getting stuff together. It was spring of 2022. And then we'd already rented our space. We were like getting ready, and we made this whole pivot to micro practice DPC. And so it all happened quickly.
Yeah, our one friend, I remember that, and she did say it's the best thing being your own boss. It's so great. And she kind of practices like quasi DPC. She runs a micro practice. She takes her patients back. She does it all herself, but she still builds insurance. And she says that it's the bane of her existence. She says, I wish if I could do it all over again, I should have done DPC. I wish I could. And I tell her, you still can. She was very clear. She's like, you guys really need to do DPC. And that was I talked to her on a Friday, and I remember this. I said, nah, that's not for us. That's not our, the typical things you hear, like, no, I don't want to, do concierge, or I want to make sure that we can treat all the patients. And I had the typical statements that a lot of people say when they don't really understand DPC. And she's like, just check it out. And so I did, and I went on Facebook, and someone told me I need to talk to Josh. And I ended up just randomly Facebook messaging Josh Umber, and he sent me a bunch of stuff, more than I needed. And I watched a couple of things, and I learned a lot in a couple hours. And by Monday, we were good to go. And we were no turning back from that point. And then we jumped on all the books and read a lot. And, the Facebook groups are so supportive. And, I don't have to tell you, but the community is absolutely amazing. And we were sold immediately, and no looking back.
So let me get us into a rabbit hole here, because I know absolutely the hesitations to go into DPC. I'm smiling because Dr. Sonia Singh, who has come out on the podcast before your guys' episode aired, she talked about how she would be in DPC doctor groups, and she would find moms, in particular, female physicians, saying, don't tell me to do DPC, was like their part of their, I'm so burned out, don't tell me to do DPC. So for both of you, before you were sold, what were the specific concerns that you guys had, knowing that you're married, you're both doctors, and you had kids to take care of, that were going through your head to fuel the hesitancy versus like, cool, DPC sounds good, I'll do it?
Well, I mean, I think that I'm the financial part of the family. Like I do all of that. And we timed this very intentionally because we paid off all of our student loans in August of 2021. which was like the exact same time that we were, having this like almost crisis of what are we going to do? So we paid it all off, and that made it so that we had the flexibility to make a lot less money for a while. And I've always been really debt averse. We drive older vehicles. We don't take fancy vacations. We're campers, like we spend money on our bikes for sure, but that's about it. And so we knew that we could shrink our lifestyle down to accommodate, a lower income. The other thing is our kids were at the perfect age because we had a kindergartner and a second grader, and we no longer needed our nanny. And our nanny was amazing. I can't say enough about her, but she was also really expensive. And I don't think we could have done this if we'd still had to pay her full time. So it was all very deliberate timing. And I think that's one thing that is important for those of us that get a lot of financial anxiety. The more you plan it, the better. And then we also saved a lot of cash so that we could flow our lifestyle for a year.
And Ryan, anything to add?
Yeah, I agree. She is the CFO of the business, that's for sure. And thank God for it, because we would be swimming in debt if it were up to me. And, those are like most couples, that's like the one thing we bicker about more than anything else. But if it weren't for Katie, we'd be in a very different place. And she's absolutely right. The really smart decisions she made has allowed us to live a very comfortable life. And right now, we have a micro practice. We have no overhead. I mean, we have very minimal overhead. It's just the two of us. We have a very small rental property that is pretty reasonable, and that's pretty much it, aside from, a couple things here and there. And we have a small patient panel, relatively speaking, for where we are in the game, and we are ecstatic with where we are. We are making a very reasonable amount, way less than we would if we were, in corporate medicine, but it's just surprising how much you can live on comfortably when you really get down to it. Now, we live in an area that is rural, so our cost of living is going to be very different than other folks, and you have to take that into consideration. But the money, it doesn't bring us happiness and joy. The satisfaction and the gratification that we get from really touching people's lives and having the time to work with people that we really care about and know really well, and having the time to spend with our family, you can't put a price on that. And, salaries for us, it's just not what matters.
And, at the same time, like, you guys aren't in the poorhouse. You guys remain, like you said, Katie, you had enough financially to float your lifestyle for a year. And because you guys are so passionate about lifestyle medicine, I think it's the type of thing that we deserve as doctors when we go into a profession where we're taking care of other people and then we forget to take care of ourselves, which happens so often in medicine. I would love to hear from you guys. What does comfortable look like for you? Because no matter where you are in the country, it's like you guys are able to sleep now. Like, Katie, that was terrible that you were having insomnia, and that is so relatable. So it's so sad that it's so relatable that, like, oh yeah, it's nice that I can sleep now as a doctor in DPC where I couldn't in my former job because of all of the things, the burnout, the regret, the guilt, the worry. Did I forget to order this lab because I was going so fast in the day? So what does comfortable look like for you guys? Because you are making the amount of money that you need to live the lifestyle that you want right now.
Well, I mean, I think we are like one full-time doctor. So we're both part-time, and by our definition of our malpractice insurance, we're part-time, and that is correct. It's like 20 hours, patient care hours a week or less, and that's where we both are. And so it makes sense that we would make one full-time doctor salary, and that's a choice. So there's a lot of things that come together for that. I mean, we bought our house back in 2017. I wouldn't be able to afford our house today if I tried to buy it on my current salary. And so I recognized how fortunate we were. At the same time, we paid off almost $600,000 in student loan debt in like 8.5, 9 years. And so though we have a really reasonable house, we had at the time in 2012, that was a lot of debt. We had a ton of student loan debt, and we didn't have it paid off by PSLF or anyone. We just paid the whole thing ourselves. And so, yes, we have an affordable house, but we had crazy debt. So I think that all kind of evens out. But we go out to eat occasionally, not all the time. And comfortable for us, we've decided to prioritize one big vacation a year. And this last year, we took the family to Ireland for 2 weeks. And we stayed with family because we happened to have family there. And it was really, really fun. And it wasn't luxurious, but it was fun. And we're going to do that every year. So that's comfortable, but we're not flying everywhere all the time. don't have really fancy cars. You know, I drive a Honda. We have an older pickup truck. Like, we don't upgrade that stuff. And with our home, we are very slowly doing the remodeling, even slower now. And that's okay. I realize that having a nice master bathroom is not going to increase my happiness. Ourselves, when we're thinking about a financial outlay, is this going to increase my happiness or not? And if it's not, we don't do it. And I think that's really important too, because we never had that time. We would just buy it and hope that it was going to do what we wanted it to do. So I don't know if that helps. And we also are able to put away money for the kids' education into our HSA and into retirement now. And that, I think, is also in the definition of being comfortable financially, is being able to put a lot of money aside.
Amazing. And Ryan, how about you in terms of when you think of how comfortable you guys are, especially because you're DPC doctors now and you have the ability to impact your own lifestyle and how you practice and the time you have to practice? What does comfort look like for you?
Yeah, I agree with that. I look at what makes me comfortable, and this is maybe outside of the definition of financial comfort, but I love the comfortability of knowing that I can get up in the morning, spend some quality time with my family, do my self-care things that are so important for me that I try to lead by example with my patients and my family, which includes whatever it might be for the day, my morning walk or some meditation or mindfulness activities, going to the gym, and all that first thing in the morning, so that by the time I get to work for the day, I am the best version of myself. And I can schedule that for whatever needs I have so that I know that I can prioritize my personal wellness. And it sounds a little selfish, but if you're not understanding that you need to advocate for yourself, you're never going to really succeed in DPC, and you should. And that's true for anything. It's really hard to do it in fee-for-service, but DPC offers you that opportunity. And so then I can set my schedule and see my patients, and they know, like, oh, wow, Ryan's looking good today. He must have got some time to himself. And not just that, but also for my family too, in that, I mean, for 8 years, there was limited time I had with my kids. And once we started DPC, we started going to their school programs for Christmas and going to their holiday parties at the school. And I never had gone to one of those when I was practicing. It's just something you don't do. You don't even think about it. It's like there's no possible way I could go somewhere at 2 p.m. in an afternoon. That's impossible. And now I just block my schedule. It's as simple as that. And it's really wonderful. It's a wonderful feeling as a parent, and it's a wonderful feeling to see my kids smile when they know that I'm there for them. And those are just some examples, but there's so much of that we can just say, you know what, we're just going to block the day and have a family day. And you know what, we can take a long weekend and do a nice trip with just us. And trying to do that kind of stuff in the traditional corporate model just doesn't work. And so that, for me, is the comfort that makes me feel secure and happy.
And you guys live in a beautiful place. I mean, if you have not, visit their website and you can see the beautiful scenery that you live in. And you guys live in the place that people vacation in. Just being at peace with, I look outside and it's a very similar environment outside for me. It's like there are lots and lots of trees and like you can see the Milky Way because you step outside, it's amazing. And I also think about, Katie, when you were talking about this amnesia for 7 or 8 years, it's like that is real. And Ryan, when you were talking about the autonomy, that I do not think that what you were saying is selfish at all, but I do think that it's so sad when we do have this amnesia, we don't even think about the things we need to speak up with whatever autonomy we may or may not have, or we may be looking for, I should say. And so this is fantastic that you guys, your kids are still young, you guys are healthy, you're able to travel. I mean, this is wonderful. But I will say here also, for those doctors like your friend who said, I wish I could do DPC, I also just want to put a call out to episodes like Dr. Rosa and Dr. Oscar Torres, Dr. Kissy Blackwell's parents, all 3 of whom are DPC doctors. But Dr. Rosa and Dr. Oscar, they transitioned their fee-for-service practice into a DPC. Dr. Andy Chun, Dr. Michael Chun, Andy is his nickname, same thing. So if you have not listened to those podcasts and you are listening and saying like, but I couldn't do it, I already have a private practice, but in fee-for-service, there are episodes to prove you wrong and to show you a way going forward. So let me ask now, in the opening timeline of your guys' practice, you're talking, guys, about, the summer of 2021, paying the loans off. And then by September of 2022, Ryan, you would open the practice. So tell us about how the strategy went in terms of Ryan, you opening, and then Katie joining on the next January.
So yeah, that was strategic also. We just figured September is a good time for folks to open up a new practice after the summer, kids back in school. It was convenient for us as well because and the timing worked well for that. And of course, we did this staggered approach because those first 6 months, I'm not generating income, not substantially by any means. And so Katie stayed on. And so we were able to kind of help float by her maintaining her salary at the program. And then once we were up and running a few months, it was kind of this like, hey, we were all in it. I don't think there was an opportunity for us to say, well, I guess we'll just go back. But Katie really needed that reassurance to say, like, okay, is this actually going to work? And luckily we could do it because we're a couple and she could see me and see the patients signing up and seeing like, and she already had a waiting list of people that really wanted to see her. And they're like, well, I'm going to sign up and wait for Katie. And I'm like, yep, sounds great. And so once she had that and she saw that, oh yes, this is really happening, then it made it a lot easier for her to kind of jump on board. And plus I had done my best to kind of work through all the administrative hurdles that inevitably happen, like how do I make the faxes work and how do I make sure that, this gets scanned in correctly and what's the process for putting in the new records and all that kind of stuff. And of course, she was always helping me on the days when she wasn't doing her other job. She, could help me do some of that stuff and then learn some of that. But it was just nice to have that staggered approach. And if you wanted to add to that, but I think.
Well, and the health insurance too.
Yeah, right.
Because private health insurance is so expensive. And it was really nice to have our corporate health insurance for about 5 more months. I think that we also gave a year's notice. You remember that? Because it's so hard to fill these spots, these faculty spots in a rural place. And so we wanted to give our program director a year. And we didn't make it public beyond that, but we just said, hey, we're going to be leaving. And I want you to know. And so that was a risk we took because they could have terminated us immediately, but we didn't think they would. And they'd asked us 8 years before. They asked us if we were ever going to leave to tell them a year ahead. So we did. And then we also had the issue of renting a space because we found this perfect space a couple months before opening. So we had to pay rent for a little while without any revenue. So that was a little bit of a challenge. I wish we hadn't had to do that, but it's been the perfect space. So all of that, that was all very planned of how we were going to open at that particular time. And then also we had to give 90 days. We had a non-solicit. So we had to be really, really careful with all of that.
As you guys were talking, I'm just laughing because I identify as the Ryan in the relationship and my husband identifies as the Katie in the relationship because we did a very similar thing in that it was like, I'm like, I don't care. I'm just doing this, man. We'll figure it out. And my husband's like, all right, so we do need health insurance and we need money. So that would be great. Like you do you, man. And I'm going to stay on at the job that brings in those two things. So I totally relate. And I'm sure that there's other couples out there who are in the same position of like, if we're both doctors, what happens if we both leave and how would we approach that? So I think that that's fantastic to hear how you guys did it. Now, in terms of the transition, Ryan, I don't know this, so that's why I want to ask, with you being heavy on OB, how did that work out in terms of your continuity patients? Because I'm sure there were some people who were delivering after you parted ways from the practice. And how have you handled OB in your DPC?
Yeah, that's a great question. And that was some difficult conversations that Katie and I had because I've always really enjoyed doing prenatal care and obstetrics and, newborn nursery care and pediatrics. And Katie and both of us really enjoy doing hospital inpatient medicine. And we had some really hard conversations and we talked like, can we make this work? I talked to a lot of DPC practices and said, how do you do it? Is it reasonable? And I looked at our community and I looked at what our patients needed. And, a lot of analysis went into that. And we decided the best thing for our practice and our ability to practice the best way that we can for our patients was, we're going to have to give up a couple of those things. And that's a personal decision. And every DPC needs to think about what brings them the most satisfaction. And for us, that was a tough decision, but it was the right decision. And we said, you know what, I'm going to hang it up regarding obstetrics and we're both going to be done doing hospital medicine. We have a great hospitalist team. We know, these are all people that we've trained because they're all graduates of the program. So we know them all really well and they're great. And I can, if it were an issue where I was concerned about the care they were going to get, I would want to take it over myself. But I know they're getting excellent, high quality care. And I'm still an advocate for my patients. I still round on them in the hospital, but I'm just not doing the ordering. And they love it. It's the best of both worlds. They're getting great care and I'm still their advocate, which is all they want anyway. As far as obstetrics goes, I have a couple patients and Katie has one or two too. And we've had to just say, you're going to have to see another OB provider in town. They're wonderful. We have a great collaborative relationship and we co-manage and they call us and we say, this is a question for your OB. And I'm sorry, I'm happy to help, but we have to have very strict lines between where we can and can't get involved. And there's some malpractice involved in that too, which we'd like to keep our malpractice cheap. And by not doing obstetrics, that really helps.
It's totally relatable. I loved doing colonoscopies for the time that I was doing them. And then I stopped doing them because it was very, very uncomfortable for me to keep battling against the corporate. They were canceling my patients without telling me. They were canceling my patients after they had prepped for the week and had showed up at the hospital because it was cheaper for them to cancel than to pay the staff, the 4 staff that were going to be in the room for the number of procedures that I was doing, which was so quantity wise, I'd probably do no more than 4 in a day because I only took care of my own patients. And it's like, I love that you say that you're patient-centered, but actually that your synonym for patient is money. So it's really frustrating. And that's just my experience, not to push that onto your guys' practice, but like that was why I gave up colonoscopies, because it was like, I can't handle the stress of continuously trying to fight for my patients. I take care of them. I'm able to do full scope care, including colonoscopies, and nobody's listening to me or nobody cares. And so it is absolutely something that goes back to your practice deserves you being there for it. And if you cannot be there for it because you are doing other things that are adding more stress and not allowing you to be free in DPC, it is absolutely reasonable to rethink, like, do I need this going forward? Even if you are amazing at those skills, it's like, it's your call because it's your life, right? So I can relate to that so much. And I'm sure other listeners can as well. Now, let me ask, one of the things that I loved about your website was this, like, hey, we're here, so let us know when you're ready to join attitude. So I wanted to ask that because the copy specifically says, once you're ready to consider a new model of primary care, send me an email or give me a call and we'll get started. So tell us about getting to this place of like, we're going to do this. Financially, we can do it. We are seeing the pros, the possibilities that DPC will allow us in the future. How did you come to this copy where it's like, yeah, we're here. You're missing out if you're not joining us?
That's a great question. I feel like we never really marketed ourselves all that hard. I mean, we definitely told people we were there. We got ourselves on the local news a couple of times just to kind of spread the word about like what we're up to. And I was on local access, like public Ask the Doctors forum a couple times. I think you did it once. Mm-hmm. And so we really just like got our names out there. And then we're already like well known in the community because we've been here a long time. So people just started talking about us. And that was a big part of it. I will also say there was another practice in town that closed rather unexpectedly. And so that was a large number of patients who needed a home. And we got probably about a quarter of them in a 3 or 4 month period. And so that did help the practice grow. It also got the word out there. And so all of our growth has been pretty much organic. Like we don't sell this all that hard to patients. And I recognize that in some markets where there's a lot of DPCs, you have to like really pound the pavement. I understand how fortunate we were that we had like name recognition already, but it has really been like, talk to us if this is what you like and we think it's a good fit, come on in. But I don't sell it because we've found in people who we've tried to sell it to, they haven't been as happy as the people who came in halfway there.
Yeah, agree. So we really, our advertising expense has been, I mean, aside from a little bit to build the website and some of the videos that we made for the website, that's pretty much it. We haven't done any advertising or anything. And we did do, I mean, early on, those first couple of weeks, there's nothing to do. I have no patience. So I am meeting all the local business owners, just getting my name out there. I did a couple cooking classes in the community, and it is a delay for those that are interested in doing that kind of stuff, at least where we are. I still have patients, and they're like, I remember you came, oh, and we also did a lot of education on healthy eating. We did a couple.
At a church.
It's called
the Seventh-day Adventist.
No, it's dinner with the doctor. And so we go up and they prepare a nice healthy meal, and then we give a little talk. And so I have a patient that signed up this week, and she's like, I don't know if you remember me, but I went to your talk and we talked about Diet Pepsi, and it was about a year ago. And so we get these people that just keep signing up way after the fact, and you just have to be okay with that. And I know that you've had lots of other folks on your program that are like, oh my God, I have 300 patients the first week. I don't know what I'm going to do. And that's awesome. I'm so glad that didn't happen to us. And I just want to push and advocate for those folks that sometimes slow growth is the way to go. We've been so happy with our growth model. And like Katie mentioned, we had that other practice shut down. And so we had to take on a good chunk in a short period of time. And that was really stressful for us. And we almost couldn't quite pull it off. And right now, we pick up a couple patients a week, and that's fine. We're at a very comfortable place, and we're really, really happy with that. It allows us the opportunity to take our time, get to know them, get their records. And that's, I think, for us, great. And I think you really want to think about what you want to do as a practice as how your growth goes. But it really does come down to word of mouth. And for us, we had a lot of fortuitous things that lined up. And when I talk to folks at the DPC summit and they say they're going to move and start a new practice, and I always have to say, you have to think about those things. If the word of mouth is the biggest thing, and if you can get involved in your community and get to know the people that live around you, all of our patients now are basically referred from our other patients. And that once you get past that hump, then your work is basically done from that point. If you're selling a good service, if you're offering the community good quality care, you don't need to tell anybody that. They're going to find you.
And they're going to describe it in their language. And I think that that's absolutely why the word of mouth works, because they're going to speak to how you're practicing DPC in your community specifically. And they're going to say like, oh yeah, when I needed Macrobid and the pharmacy was closed because it was Thanksgiving, like I just called my doctor and went to go pick it up. And that was it. There was no fuss. There was no like, I have to traverse the 30 minutes of maybe plowed roads to get to the local big box pharmacy. That's things like that can disappear. And that's what patients talk about. It's so unique, their own way of advertising for us. And we definitely see that in our practice. And I just will also echo, absolutely. Like I did not open like Dr. Kissy Blackwhite. I mentioned her and her parents, but it's like she had 278 patients on day one. I had 0. And I was so excited to have 0 because after even talking with so many people up until the point where I opened, I was like, oh my God, what do I do? And when a patient signs up, like I should know this. It's like when they hand you your baby when you go home from the hospital, you're like, no, I don't know how to take care of a baby. I'm just a doctor. I tell other people how to take care of them. So I love that you are absolutely right in advocating for you open as you open. Like even if you do have 278 patients, you can choose to say like, we're onboarding 10 per week, or we're onboarding 3 per week for the first 4 weeks, whatever you want to do. But absolutely, you get to control that spigot.
Yeah, we did do that actually. When it got really hectic, we just said, when you're a member, we're going to see you same day or next day. But before we get you in, it's going to be a little bit. And people understood. And if they didn't, that's okay too. And that's one of the other things, I guess I thought of this when you were asking that question also, as far as what we really tell folks when they sign up. So we definitely do a meet and greet for all of our patients. I think that it's really important. I know some DPCs don't do meet and greets, but for us, it's imperative. It just helps us to ensure that we're going to have a good relationship going forward. It's very rare. I don't think we've ever turned anybody away, but that we've had 1 or 2 that are like, yeah, I guess this isn't for me. And had we not had the meet and greet, it might have been a more difficult conversation. And so I find that so imperative. And when we sit down with them, we say right up front, like, listen, you have expectations. You're signing a contract, and your part is item 8, patient expectations. And we have it outlined right there. And we say, listen, we're expecting you to be open and honest with us. We're expecting you to be an advocate for your own healthcare. We expect you to be engaged. And I think that's really important. We don't practice medicine where it's just like, here's your pills, see you in 3 months. This is a totally different style. And a lot of patients say, this is so different. I'm like, I know, but you're going to have homework and you're going to have stuff that you need to do. And we're going to follow up on it. And you're going to have goals. And we're going to see how you're doing, because that's how healthcare needs to be. The old-fashioned model doesn't work. And we know that.
And tell me, especially Katie, with you coming on after Ryan had been in the practice a few months, when you started doing meet and greets yourself, had you just, listened in? Had you done some rehearsals together? How did you guys come to a point where both of you were doing your meet and greets? And I might be wrong in assuming that you guys do your meet and greets for your own patients.
Well, when it was really wild there, we would just, whoever was available would just do it. And like the other one would just like pop their head in and be like, hey, I'm Dr. Ryan, I'm Dr. Katie. But you kind of read the room because every meet and greet is a little bit different because somebody is like all in. They're like, I was in a DPC in whatever state, I moved here, I get it, I want this, I've read your website, we're good. And so like those people are really quick. And other people, especially folks, it's honestly like the Medicare discussion is one of the hardest. And so that meet and greet kind of has its own flavor as you're talking about what it means to be opted out of Medicare and why they get to keep their Medicare and that kind of thing. So we really you just start doing them. And frankly, most of our early ones were people that we knew. And so I think that's where we kind of learned was with people that we had long-term relationships with already. So we were just going through it together. I don't know. It's a small town. And I think that's the other advantage we have is we are in a small town. We know everybody.
And I think this is true for anybody who's learning DPC or just starting out DPC. It's stressful. It's like, I don't know, it's hard to really explain it in a concise way. And it's like, you want to practice that elevator pitch, right? You talk about that, you read about it in the books. It comes from practice. I mean, I gave a nice talk last night at our local university to the pre-med club. And I just didn't even have to think about it. I'm like, well, this is DPC and this is why it's great. And this is what we do. And it was, really motivating. And I remember my first time trying to explain to somebody, I'm like, well, we just don't take insurance. And you kind of fumble through it. But when you do it enough times, it just becomes automatic. And so it takes practice like with everything. The first time you have to draw labs, you're like, but oh my gosh, this stuff now I can draw labs and spin them and print the labels and get it all done in 3 minutes. And it's super slick and easy. But the first time you do it, it's just like anything, it has to become a pattern of recognition.
Love it. And tell us about your guys' ribbon cutting, because this is fresh in my mind. We had a ribbon cutting ourselves just because we are in a brand new clinic space. And so for you guys, what was that experience like? And what were your big takeaways from after the ribbon cutting ceremony had happened?
Oh, the ribbon cutting was actually kind of funny because I had a non-solicit and I was still working for the corporate system. And it actually already been disciplined a little for putting my business card into a business after hours drawing. And so I didn't do that again. So we were like, can I come to the ribbon cutting because I still work at corporate? And then the CEO, who's no longer the CEO of our hospital showed up. And I'm like, I guess I can be here. And so that it was really neat. It was such a surprise to see so many community members there. And then the Chamber of Commerce was there. And it was a really neat thing.
Yeah, they're really supportive. And I think for anybody who is looking to start, talk to your local organizations. They love this kind of stuff. They want to support you. They bring a whole bunch of people just to make it look like there's a huge crowd. It's really going to give you the big scissors and all that. It's super fun. But the CEO bit, I want to share another story. And because I've had this conversation with people, because so many times you can have these bridges that get torched because there's this horrible relationship with your CEO or with your whatever your employer is, and there's all these non-competes and non-solicits and all this stuff, and we have plenty of friends and colleagues and folks in DPC that are like, well, I guess I'm stuck traveling 100 miles away or not opening my practice or doing all this other stuff. And I know it's easier said than done, but what worked really well for us is I had a really good relationship with my CEO, and I made an effort to just be, even though I didn't love the model, I just wanted to have a good relationship. And we sat down and I said, I hope you could write me a letter and explain to him why I'm not going to be taking his patients away and why I'm still going to be supporting my local hospital. And he said, yeah, that makes perfect sense. I'll write you your letter and get rid of that non-compete. And that was helpful. And I know that's not always possible in every situation, but so often there are opportunities that we can really help to. And the thing is because of that, now we have a great relationship with our local hospital, which we live in a rural area. We don't have a choice. We have to send people to our hospital. We have to support our local hospital, whether we like the administration or not. And, we have to play well in the sandbox. And because of that, now I have a great relationship with all of the folks that get, so when my patients need to see nephrology or they need to be admitted, they're going to be going there. And I want to be able to communicate with those folks. I want to be able to see them in the hospital. And I'm still on a lot of different boards at the hospital. And I think that relationship has really helped us, stay knowledgeable about the specialists and the docs that my patients are going to be seeing, but also has helped to maintain quality relationships. And that's so important. And again, easier said than done sometimes, but I would encourage everybody to try to make an effort to do so.
And can you guys speak to any tips that you might have on maintaining those relationships the farther you are into DPC? Because for us, I think about the specialists that we do have, they're 45 minutes away. And so I'd love to hear your guys' take on, do you intentionally drop off Christmas cookies, or do you, say, hey, just wanted to say thanks for taking care of my patients? How do you guys approach maintaining the relationship?
We actually send thank you cards sometimes. And we try to rotate who gets one based on whatever we're thanking them for, like taking good care of our patient or getting them in quick or whatever. And so that is written thank you cards. That's something that we do. We go to every single medical staff event that we can make it to. Even though when we look around the room, we're like, oh, it's the usual suspects again. It's always the same people. But we always go, even when we don't want to. And then we've been I'm in a healthy aging book club with a bunch of different docs in the area. Some of us private, actually the entire group last time was private, but you have to work on it and you have to go out of your way sometimes to talk to people. And thinking about that question, we could do a better job with some of the newer people that have come on that may not know us. But Ryan's gonna be chief of staff in January, and that keeps his name up there for people to hear about. And I always speak up at the medical staff quarterly meetings, even though I don't do hospital medicine anymore, I'm still on staff. And so that's really important to just keep getting involved. And people have stopped doing that. It's so frustrating for me to look around these medical staff meetings and know everybody there, because I'm there's a whole bunch of people in this town who are awesome, who I don't know. It'd be really nice if they would come. And so that's a big thing. Stay involved as much as your hospital will let you. Go to the ice cream social. It'll be fine.
I love that. And just you guys mentioning the Chamber of Commerce, our local Chamber of Commerce, as I'm sure is probably common with other chambers, they advertised on their, profile and platform about our ribbon cutting ceremony. And so especially the people who are part of the chamber or who are looking at their page who are in the healthcare industry of whatever sort, we had some of those people show up at our ribbon cutting ceremony just because of that co-advertising of our event. And so I think that absolutely, I agree, being present for your community matters. So that's awesome. And I will say, also, just going back to the non-compete, non-solicit part, if you are listening and you're facing that, definitely listen to Dr. Andy Burkowski's episode. Super innovative way as to how to deal and cope with the don't pee on my territory, crappy contract clauses that there are. So now I wanted to ask you guys about your website has pricing, but you also strategically have pricing from Fair Health Consumer, as well as your pricing for what a pap smear costs or what a medication costs. So can you tell us about how helpful it's been for your community, for people, whether they saw you at your prior practice or not, in terms of comments you've heard from your patients and or members who've joined about the value of the comparison between what you could pay and what you do pay because of being a DPC member?
Yeah, I think it depends on the patient, but it's all relative. I've definitely had some patients, and I think Katie can speak to that too, where I've had certainly a handful of patients who, if they're on a good number of meds and even if they have a decent insurance plan, the copays and everything ends up costing a lot more than what we can get our medications for. And so I definitely have a number of patients who, at the end of all of that, end up saving more than their membership on meds and sometimes labs. And so they're like, well, that's a no-brainer there. So that's been great. And some folks don't see the benefit there. They're like, well, my insurance pays for all my meds, so I don't need it. And I'm like, okay, that's fine. I understand that, but it's just nice to have that option. People, I think, don't recognize that they have a choice, but it's nice to be able to say, listen, if you want me to draw your labs, I will. I'm just going to charge a cost for them. We don't make money on that, but this is what our cost is. And it's almost always cheaper than their copay. and it's convenient because it's right there. And the same thing with meds. I'm like, you can get your meds from here, but I'm more than happy to send them to the pharmacy. It's up to you. And so they really appreciate just having the opportunity to choose for themselves. And then, of course, we do the same thing with some of the imaging. We do have, so when we bought our practice, well, we didn't buy, but when we rented our practice location, we actually rented it planning a fee-for-service clinic. And so we have like 6 exam rooms and a procedure room and a waiting room. And then we decided to do DPC. We're like, what are we going to do with all this space? And we rent out one of the rooms to an ultrasound tech, and she's awesome. So she's here once a week. She does ultrasounds for anybody in the community, but for our folks, if they want to see her, she does bill insurance, but she also gives us a great cash price. And they love that. And then, we also partner with the urgent care down the road and does a great discount on x-ray and all those types of things we try to negotiate. So folks can really see the benefits there.
I will say we don't partner with the urgent care. We have a cash price list that the urgent care gave us.
Sure.
That they offer to everybody in the community. But it's nice to have places that are willing to offer a cash price pay for our uninsured and underinsured people.
But they are really good friends of ours.
And they're friends of ours.
And whenever I need something like supplies, they're like, yeah, come on down, I'll get you a urine pad or whatever. Or if we're late on our Quest pickup, I just zip it down there and the courier grabs it, or whatever. They're really great and they're super supportive, and they're always great to get our folks in if we're in a pinch. Because when you're a micro practice like us and we have no overseeing coverage when we're both on vacation, it's nice to know that our patients have a backup plan that's not sitting in the ER and overwhelming.
And I'm sure that you guys also, like you mentioned, the expectations, the homework that you're giving your patients, the expectation that they can advocate for themselves, the expectation that like, hey, we are married, we will go on vacation and we will not be in town 24/7, 365. I think it's so important for people to think about that, especially if their website states 24/7, 365, or if they're going into this as a couple. So super important. And, just in terms of the cash pricing, I think that one added value is for people who have not even thought about there's a cash price for this. Like it literally is really cool to see that because people have no idea how much things actually cost. I had this conversation with somebody about TSH, and they pay $204 for their TSH after their insurance kicks in. And I said, what? I don't remember what our prices are, but let me text you later. I think they're $8. And so my text to this person was, oops, I made a mistake on the pricing. It's $6. And so, it's just like, I think it does plant the seed as you guys have. I mean, like the people who are coming into your practice a year later because they heard your talk or whatever, it's the same idea. Like you're planting seeds in people's heads of, wait a minute, how come that lab, I think I saw something about like it was less than $10. Like, but I paid $60 for that same lab or medication or whatever. So even if your patients don't use it, it's still a very cool thing for people to see. So just, food for thought there. Another thing when we talk about pricing is you guys have a price that is fairly inexpensive for a child, but it also requires an adult membership. So tell us the strategy there to definitely promote the family medicine portion of your practice.
I think that was intentional because I don't think you could take care of kids without taking care of at least one of the parents. I mean, that's the part I always loved about family medicine. And so that's why we price the kids so inexpensively. But we won't even take kids who don't have an enrolled parent unless their only catch there is if they're heading to college and they're young. We'll work with it and put them at a higher price point. But yeah, I think that was to grow the kids side of the practice because $25 a month is really reasonable. And I have a number of kids who actually still see their pediatrician because they can get their vaccines there. And we don't have a volume high enough to give vaccines, which breaks my heart. But then basically they're paying $25 a month for an urgent care membership. And they really like that. And I like it too. I see the kids regularly and it works really well. And then the older kids that don't need as many vaccines, they generally drop their pediatrician and just see me and then go to the health department for vaccines.
And definitely that is a thing. Many people use that strategy of use your fee-for-service doctor, because they can get vaccines easier, or you're afraid that your insurance is going to drop you if you don't see your fee-for-service doctor once a year. Like, those concerns definitely come out. I think that's very common for people to have their fee-for-service doctor, and then they have their DPC doctor who they can access when they need to. So I think that is absolutely something that people can relate to. Now, in terms of advocacy, Katie, you mentioned how Ryan's going to be chief of staff at the hospital. And in general, you guys are still, involved in the community, involved when it comes to talking to people about not only the power of family medicine, because you have the time to take care of your patients, but also just the movement in general. So can you guys speak to how do you guys speak about DPC in your community, and how can other people think about what you're doing and build off of that to advocate for the movement as a whole?
So one of the things that I find difficult and discouraging that I'm trying to do my best to help support is that a lot of people are getting burned out, and they're getting, and we talked a little bit about that earlier in the hour here, but people are so fried, they just don't want to, they're like, listen, I'm just punching my time card. I'm in and out. I'm busy enough as it is. I don't have anything left to give, right? And I understand that. And sometimes even with DPC, folks are like, I'm burned out from the system. Why would I want to go back and help? Why do I want to, be involved in advocacy? I just want to do my thing. It works for me. It pays the bills. It improves my life. And I think that's great too. But we're doing direct primary care, at least on some level, because it's a solution to a broken healthcare system. And I recognize that DPC isn't going to solve the problems for everything. It can't, right? But it's at least a step in the right direction. And as long as we continue, and you know this and I know this, but the DPC movement is growing so strongly right now. It's a force, and we need to harness all these empowered and passionate individuals to really voice the change that we need to see in medicine, and start to turn away from this angry, frustrated, burnt out mentality. And that's easy for me to say because I've been doing this for 2 years and I drank the Kool-Aid, but we all need to start drinking the Kool-Aid so we can start feeling good about it, so we can get back to making this a better system. And there's no way around it. Health insurance isn't going anywhere. People are going to have some kind of health insurance in some form or fashion. Corporate medicine is there, and we have to do the best we can with it. And I would love to see these things change, but if we don't do it on a grassroots level, it's not going to get better. And so whatever that means to you, you have to find a way to advocate for yourself. And for us, getting DPC out there and vocalizing for why it's effective and how it can be meaningful, and getting out at your local level or your state level or even your county level and being more of an advocate and a voice goes a real long way. And it can really help patients get the care that they need.
And Katie, do you have your own take or anything to add on that?
I think part of echoing what you already said, is that in DPC, we have the time to do that. I'm more willing to say, yes, I'll come to this evening thing. I'll do the Ask the Doctors again. I'll talk at the library on plant-based eating because I'm not so tired from my regular job and all my regular commitments. And so I think that's almost something that's important. When you have the time, you've got to do a little bit. And Ryan, I will say, does more of the official advocacy work. Whenever, I'm sure that some doctor couples can make it work where they're both really involved in everything. But I think most of the time somebody steps back a little bit. Like as an example, I don't go to the family medicine department meetings. I just don't. They're at 7 a.m. and somebody's got to do the breakfasts and the lunches and get the kids on the bus. And that's me. And so I don't go to a lot of things anymore, especially in the morning. And that's a choice. And so I'm not on as many things, but I'm more willing to say yes to community events to get that word out that there's another way.
And I think it really highlights the importance of education in the advocacy that we are all doing, at some level, whether it be talking to our patients, clarifying that's because you have insurance that caused, you to not get this sooner, or that caused, you to pay a higher price or whatever it is. Patients and doctors and organizations, whatever, need to know what we're doing. And the way we tell people about what we're doing is, one, doing it, and two, we talk about it, because that is one thing that I see over and over and over again, even at our state medical society. So what is the difference between DPC and concierge? Like at our state level, people are asking basic questions, and great, fantastic that you're asking. I appreciate when people do ask rather than assume, but I think that it's wonderful that you've seen one DPC, you've taken care of your patient in the way that you took care of them. And that is really hard to replicate, and it's really hard to be represented in a fee-for-service model. And so speaking to how we're doing things differently, whether or not you're burned out, like Ryan, how you pointed out in the beginning, it doesn't matter. It's the way that you're doing medicine absolutely changes when you have a direct primary care model behind how you're practicing medicine. So that's a wrap for today's episode. Thank you so much for tuning in. We're going to continue the conversation over in our Patreon community. We're going to be talking about how Dr. Katie and Dr. Ryan are actively integrating quality menopause care and culinary medicine into their practice, and how they're going forward as a married couple who are also doctors. So join us in our Patreon community to hear more of the conversation. You can find the link to the Patreon community at our homepage at mydpcstory.com. Thank you guys so much for sharing your story today.
Thank you for having us.
Thanks for having us.
This was great.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Marielle Concepcion.